8% are severe, 15% may get better, and 5% may become critical, and that's most of the mortality. So the disease severity versus timing, this is a very important slide. This is what they talk about, flattening the curve. They don't want to get up here, they want to stay here. This is the severity. The virus response and the host response, this is important. We die and people die from this disease mostly because of the host immunity. So people get the infection over time, get symptomatic, either symptomatic and then come down in the curve, or they escalate to become severe. And when they become severe, either they go up all the way to unfortunate death, or they recover again. This just summarizes how this part happens. Very quickly, age and comorbidity, that's very important. The older people are, the more likely become more in the 5% group. Comorbidities, and this have changed significantly. There are diseases of people, even in young people, that cause bad outcomes. This is where we are now with comorbidities. So obesity, diabetes, hypertension, cardiac diseases, all these things, if they happen in patients, if the infection happens in these patients, they are the more likely ones who will progress to the bad stages. Lung diseases, we initially thought that it's going to be part of that, but apparently we are not seeing as much as we thought we would. And rheumatic diseases, malignancy also should be in this group, even though malignancy have its own challenges in general. I mean, somebody have malignancy on chemo, for example, no matter what the infection is, the outcome usually is not favorable. So this is where we are right now. And as I said, things are fluid. This may change anytime. These are the main labs. I brought this up just to show what labs changes happen with the infection. And we'll talk about this in a little bit more details. This is how the CT scan looks. This is a patient that a nurse who came, and she looks horrible the time I saw her in consultation, which is the second day after she got admitted. And then I transferred her to the ICU. We did manage her very well after we got her to the ICU by just BiPAP and high flow with extreme precaution to the operators. But unfortunately, on day 4 or 5, she collapsed and got intubated. And right now she's intubated, kind of stable, but we expect a few days before we can turn her around. This is how we should approach a patient who comes in, and I took this from the public domain. I don't necessarily do everything, but this is a way to describe. So any patient comes in, because it's not just COVID. I mean, when you receive somebody in the ER, you have to go through other diagnoses as well. So patients who come in with symptoms that may suggest COVID, we do chest X-ray. Some places I don't do that, but some places do ultrasound of the lung. Then we do the COVID test, of course, if the suspicion is there. We do CPC, and I would add to that CMP, which is the kidney function, liver function, and electrolytes. C-reactive protein I do, prolactin, and I don't do. And if collectively what we did diagnosed COVID, then we have a COVID and we'll go to progress to the next stage. If not, depending, not with a low degree of suspicion, which I'm not quite sure why would you do the test if there's low degree of suspicion, but nonetheless, if it is negative, then COVID with good probabilities has been ruled out. If it is, or the test is negative, but you still have degree of suspicion, then what I do is a CT scan. And then if there is typical findings of COVID, I will repeat the PCR in 48 hours and take it from there. The only reason I put this slide is to show that things are fluid. Many things here, many medicine here, like at the Zinavir, we don't use anymore hydroxychloroquine. Still, some people use it. I have one patient on it, but it's not the main drug right now. I'll talk a little bit later about drug therapy. This is another cartoon to show the way we do things. I'm not going to talk too much about it because we just talked. Okay. In terms of, as we said, it's a droplet infection. It goes directly from a person to person or indirectly when an infected person coughs or sneezes or produces some of his droplets on these surfaces. These are very important. They go from few hours to several days. This is interesting. Your mask may harbor the virus for a week, so we need to be careful. Money, wood, cardboard, metal money. So all these things need to be considered as a part of the spread of the infection. This is a very important slide. So early in the pandemic, when it's not even announced yet, there was a Chinese auto executive, I guess, in Germany. He went there. He did not have the symptoms until he traveled back home. During that time, he was infected. This shows the asymptomatic infected people who spread the disease. That's where we got our 2 days or so prior to symptoms infectivity. So the index guy, the index patient, went home without symptoms. The first patient was in contact with him. He developed symptoms in a few days and was positive. Patient number 2, a day or so after, and got positive. And patients number 3 and 4 actually never met patient number 1. The index got it from either 1 or 2, and also developed symptoms after a small hiatus of a day or 2 of no symptoms. So this is how or what made us change our view of this as a potential of asymptomatic spread. Incubation period. I see and hear a lot talked about this particular issue. It has been determined that incubation period goes from 1 to 14 days. People can have incubation period of just 1 day. It depends on the viral load they got and snuffed in, depends on their immunity, etc. So you could have symptoms 1 day after you get infected up to 14 days, and some authorities say even maybe more. Patient is infectious 2 days before symptoms, more or less. Patient, even after, and this is important because there's misconception out there, after incubation period, you still are contagious, and I'll talk more about that. So why I'm stressing on this, because incubation period applies to a person. It does not apply to a group. And what I'm getting at with this is our hotel quarantines. I have concerns about that in people who are stuck outside the country, that we're putting them in a hotel unless they do the strict quarantining, where, like what you saw in some of the early clips from China, where even a robot go between room to a room. That may work, but having people gather in the hallway, do protests, tape videos, that will actually make the problem even worse. This is an important finding as well. So the coronavirus PCR may remain positive up to 6 weeks. That does not mean infectivity for 6 weeks, a group in Germany and in Winnipeg, Canada, found out in two small, tiny studies that people who still remain positive in their PCR do not culture in their secretions any virus on day 8, according to the Germans, and day 10, according to the Canadians. Those are small studies, the German about 8 patients, the Canadian about 20 patients. They saw that the PCR is still positive, yet the cultures of the secretions from these patients stopped showing virus or growing virus. Therefore, they are not infectious. Based on those two studies, then we started to talk about infectivity and time to stop isolation. When do we do that? Patient came to the hospital, tested positive. I'm going to keep him for a month, 2 months, days. So they divvy that up to symptomatic-based strategies and time-based strategies. So the symptomatic are the people who come with symptoms. So 10 days after the PCR positive and or the symptoms started, even if they are improving cough, you don't need to, it takes a while for the cough to go away. So as long as it's improving and the patient is afebrile for 3 days, 10 days is enough for isolation and they can be discharged from isolation. On the other hand, people who have no symptoms just because they are contacts, etc., of patient who had it, and we did the test and we found him positive, we just keep him for 10 days and then we consider him as safe to get out of isolation. I'm not going to talk about too much about medicine for the simple reason is that we have no idea what works and what not, and we do not have any medicine that can cause or can treat this. We had hydroxychloroquine based on the fact that it has some modality, some immune modulation, so it acts on the virus and on the host. It increases the pH in the lysosome. It kills the virus theoretically, but evidence are coming out that we're seeing more complication than benefit, and people are backing off. So I only have one patient now on hydroxychloroquine under a very close observation, mostly cardiac. The one in the middle is the remdesivir, and it is the promising medicine that is just gained a approval the last few days for emergency use. So it's not an FDA approved completely, just for the emergency use. And it works a little bit in like Tamiflu for flu. It does not cure the disease, but it may tailor down or cut down the symptomatic patient. I think it's something from 16 to 10 or something around that. And people would say, well, what's the importance of that? That's actually, if that stands and that proved to be the case, that's very good, because as we know, the mortality from COVID is because of the rush and because of the congestion of health facilities that it causes. So if I can cut the time where we need to take care of the patient and free ventilators and free ICU beds, that's huge. So this has some potential. The last one is the plasma. This has been used since the early pandemic in 1918. And basically it's simple. They spin it off, they get the plasma out of the blood of the people who got infected and mounted antibodies. And then they inject it to patients or part of it to patients, and hope to boost their immunity towards these viruses. That they are still work on this, and our institution, we are participating in one of the bigger studies, so hopefully we'll get some results soon. A big talk is going on about why in Libya, for example, we have small numbers and of infections. What's the role of BCG? Well, as of now, there is no role or rule that is approved for BCG to have anything to do with COVID. The supply is not huge, and the TB is still the main killer in the world, and we still need to vaccinate kids to try to cut that down. So nobody's using BCG as of now, but there are two big studies, the BRACE trial and the BCG control corona trial in Germany, sorry, I think it's in Holland and in Australia. And they are, we're just gonna wait for their recommendations before we proceed any further. So there's no role, even though there is still a theory and hypothesis that BCG can control or help with coronavirus infection. This is a new development about the thromboembolism and the, as I said earlier, the COVID toes. The quoting from a doctor in New York, Dr. Piccadilly, he said, "I have never, ever seen high levels of D-dimers." D-dimers, we test those and we see those. They are not very specific, but they tend to go up and down with the status of the coagulation homeostasis in the body. So we see high numbers, but not as high. I mean, the regular numbers we see for PE and DVT is much lower than what we see now. They're huge, huge numbers. So over the last couple of weeks, the institution has been shifting towards more prophylactic. So the more common, even though not everybody is doing the same, but the more people using is prophylactic with low molecular weight heparin for all COVID people. The high dimer people in some institutions, they actually are more aggressive and do full anticoagulation. The important point here is the anticoagulation, however you used it and whatever you used, like oral or heparin or low molecular weight heparin, the need for treatment for people that you determined that they needed to start with should extend beyond hospitalization. So some studies 30, some authorities go 45 days after the diagnosis. So this is very important. This have changed the paradigm of treatment, and we're seeing more and more blue toes now with this disease. Another thing, people talking about the ACE inhibitors, and are they protecting or are they making things worse? As a matter of fact, there are two hypotheses. The hypothesis in the top, using the ACE inhibitor will upregulate the receptors, meaning making more of them to accommodate. We know that the ACE receptors are the receptors that get the virus in the body. So with ACE inhibitors, some people say we are upregulating, causing more of it available for viruses to get into the body, and that's a harmful effect. The other hypothesis is that once you are blocking the angiotensin 1 to 2 conversion, you are sort of fueling the other side of the reaction where angiotensin 2 goes to angiotensin 1 to 7, and this causes inflammation that sometimes end up by fibrosis, and that might cause some immune modulation that would help. Nothing is proven yet. It's only hypothesis. The recommendation of the American cardiology authorities are recommending whoever is an ACE stay on an ACE inhibitor, no change, and no ACE inhibitors just for the COVID. Just changing to how things are reported, this is my recommendations. If we end up having the outbreak in Tripoli or in Libya, we should have documentation of our status, where we are, how many cases in this area. what's the situation in different institutions, saying, like in my institution, St. Joseph Hospital, according to that day, we had 18 active cases. We have 10 under investigation. We wrote down how many beds we still have, what is the status with the PPE, how many we have it or not. And this just helps authorities within the institutions and doctors to get a sense of where we are with this pandemic. The graph in the bottom is the daily diagnosis over the month of April. As you see, this is only in the county where I live in. It got as high as 60 a day and as low as 0 on April 7th. Let's take a case. This is a 57-year-old male. He went to 2 ERs with similar symptoms. Both was tested for COVID, both came back negative. He went home. The fever didn't go away, the headache is worse, the body aches is worse, so he came back to the other ER, which is our ER. All cultures, and I will show pneumonia, serology, everything came back negative. Normal CBC, normal CMP. These are days, so the ones that I'm not showing are in different days. So this is the, at least part of the workup that's done to this person in terms of atypical pneumonia, and all is negative. This is his temperature curve. This is normal. This is high fever. He got as high as 104 and down to almost afebrile. So the fever is a big thing. This is oxygen saturation. Mainly he was doing fine, but I think he had either an outlier or a real dip here, at which time he received oxygen. And after we took him off oxygen, he started drifting down, and now he's back on 3 liters. This is his CT scan. It looks more or less typical, with this fluffy interstitial in some parts, a little bit deeper in other parts. This has been seen more and more with patients with COVID. This is another CT, the coronal sections of the CT scan, just showing it from a different angle. And lo and behold, in the 3rd specimen that we sent, it came back positive, which adds to the challenge of managing and diagnosing people with COVID. So he is only on supportive care right now. He's not on antibiotics, except for a broad spectrum that was started before we even diagnosed it, thinking that this is a ARDS or pneumonia. He was not on any oxygen, but now he is 3 liters. And the only or mainly thing we're doing, well, actually 2 things I didn't add. The other one is proning and BiPAP/Vapotrim that we keep on using off and on. And Dr. Mohammed Turki tomorrow will probably talk to us more about proning. This is another case, and this is the challenge that this pandemic is giving us. This is probably not COVID. You can see there's some effusion that we don't see with COVID. But this patient had shown early enough a denser interstitial, not so much bronchoalveolar, with a hazy background of interstitial process. 6 days later, the dense opacities we are seeing are getting less denser, but we're seeing more of the interstitial. This patient also received 2 negative, but the 3rd one is still pending. It was pending until yesterday, and today it came back the day before yesterday. I'm still in yesterday's time. So yesterday we got the result as the 3rd one is negative. So this patient is transferred to a SNF facility on room air, and she will receive more workup once this pandemic is off. This is probably a case of lung fibrosis. What came in association with this pandemic? Because everything we are saying right now could change. Nothing is proven with uncertainty, even though there's no no escape from uncertainty. In medicine, nothing is 100%, but this pandemic is giving us a challenge. These are some people who came up with sort of very extreme opinions. Some of them are comical, some of them are real. This German professor is reportedly well renowned person, and as you can tell here, his recommendations are not what we're doing. He's basing it on some hypothesis. This guy, when he talks about his credentials, he have like 3-4 lines. He is just pretty much saying everything opposite to what we're doing right now. And these two guys are debating whether we need to do the quarantine or not. And quite frankly, that's the only thing that is working for us now. And this is the comical part. The guy who's, I think it's some sort of mlukhia or something, said that it improves chances of getting over corona. So you see there, because of the uncertainty, it is opening the door for many people to come up with different theories, and that's clouding the view, and we need to be cautious to what we hear. This is a summary. I don't want to go through it. It is how you approach a patient and treat with or manage with COVID. This is how now we are practicing medicine, at least in part. We just do a teleconferences and try to make sure people are alive until we see them in clinic, and make sure that we take care of their immediate needs, etc. We try to avoid having them come in contacts. These are the many phases of COVID. This is how I looked over the last month and a half. And for everybody in Libya, if there's any need or any question for me personally on anything, I'm available anytime. Just send me an email. Finally, I want to conclude with asking for dua to our beloved friend who's suffering from COVID. I just heard today that his things are getting better. He got a trach. I don't know if he's off the ventilator or not, but he is getting better. This guy was my colleague in Tripoli Central Hospital. We were intensivists together over there, and he contracted the virus in online of duty. Thank you so very much, everybody, for your kind attention. Dr. Yahya is going to come next, and after that, Dr. Ramesh. And then we'll have some, if time allows, discussion panel. Thank you so much. Khaled, are you there?
ايوه دكتور خالد، شكرا جزيلا ليك على على التقديم. لو كان في حد من الجماعه عنده سؤال حنعطوا 5 minutes questions لغايه لما دكتور يحيى if he is there let me know. اوكي دكتور يحيى you are back. دكتور عصام حتى هو who joined us كان دكتور عصام تبي تقول كلمه ما بين مجموعه جهزوا كان عندهم سؤال. تفضل دكتور عصام. دكتور عصام.
ايوه السلام عليكم.
وعليكم السلام ورحمه الله.
عذرا
يعني نعرف انك انت في المنوبه.
لا بس I'm good لان I was not unmuted بس يعني الله يبارك فيك. بسم الله الرحمن الرحيم. طبعا احنا we want the presentations to go يعني بس كتعريف يعني بالنيابه عن التحالف الليبي الامريكي والفريق الطبي بقيادته وبرياده الدكتور خالد العايل وكل الاخوه الافاضل، نشكر الحقيقه الجميع للمشاركه، دكاترتنا الافاضل الدكتور خالد الهديلي والدكتور يحيى التجوري، وانا معكم ايضا ان شاء الله في الكلمه. نشكركم جدا على المشاركه، ونتمنى الحقيقه ان يكون لها ان شاء الله الفائده المرجوه التي تعين الجميع ان شاء الله لمواجهه هذه الجائحه. يعني الكلام لعله إن شاء الله الأهم والأولى هو للمقدمات أو عفوا للعروض. فأشكركم على ذلك، وأنا إن شاء الله سأعرف بنفسي قليلا عندما يأتي الوقت لعرض المشاركة أو المساهمة بتاعي إن شاء الله. شكرا لك أخي خالد.
شكرا دكتور عصام. دكتور يحيى تفضل. أول شيء كان في سؤال قبل تبدأ دكتور يحيى، متأسف جماعة لو كان في أي حد عنده سؤال. دكتور عبد النبي عندك سؤال؟ If you can unmute everybody just for minutes, so if anybody have questions please.
دكتور خالد السلام عليكم.
تفضل دكتور عبد النبي.
السلام عليكم ورحمة الله وبركاته.
لو كانت بدير مداخلة أو عندك أي نوع من الملاحظات تفضل.
السلام عليكم.
وعليكم السلام.
مشكورين جدا على المجهود، وبصراحة محاضرة قيمة جدا للدكتور الهديلي. لاحظت أن الحالات اللي الزوز أو الحالة أو على الأقل حالة واحدة اللي تأكدت من مشاهدتي لها 100% أنهم there was delay in doing the HRCT. هذا باش الآخر الدياجنوزس. البي سي ار طلعوا ممكن 2 أو 3 نيجاتيف. فأنا استغربت في الحالات هذه ليش ما داروا لهمش HRCT. يعني في بعض الدراسات تقول السنسيتيفيتي بتاعها 97% بالذات في السيمتوماتيك كيسز. من ناحيه المانجمنت بصراحه وي ار ان بيج دايلما. للاسف فيه بريشر هلبة من الشركات الادويه باش يجيبوا ريمديزفير، واليوم كلموني من المركز الوطني للاسف اللوبي نتاع شركات الادويه هنا قوي شويه. فاحنا بعد ما سمعنا انها allowed to be used من ال FDA، مش approved لكن allowed to be used، فنفكروا نجيبوا منها كميات بسيطه. طبعا هم ما يكتفوش بكميات بسيطه للاسف. جماعه الشركات عندنا هنا يفكروا يجيبوا بكميات كبيره، والحالات اللي عندنا احنا تو كلهم 63 على الاقل اللي ديسكفرد ودايجنوزد. فنبغى توجيه منكم في هذا الخصوص. كل الحالات اللي مرت علينا ما استعملنا لهاش اني تريتمنت، حتى الحاج الاول اللي كنت انا مسؤول مباشر على علاجه الحمد لله شوفي بعون من الله سبحانه وتعالى، مش بفلاحه من احنا وغيره، مجرد توفيق من الله. فشوفي without using any specific drug، يعني just antibiotics. صار له شويه complications في الرئه طبعا، mild fibrosis هذا اللي expected في السيت سكان الاخير اللي درناه له لما وديناه للديسشارج. فاكيد حتتناولوا الموضوع هذا انتم بعدين ك treatment options and your recommendation for us as specific treatment of COVID if there is any. We know that there is no approved treatment، لكن توجيهاتكم اكيد حتساعدنا. مشكورين جدا، وتعليقكم على المواضيع هذه لو سمحتوا.
شكرا دكتور عبد النبي. دكتور خالد تفضل ان نستمر وناخذ الاسئله في الاخير، ولا تفضل ان تاخذ الاسئله تو تجاوب عليها، لان عندنا كذلك الاخ هشام القبلاوي عنده سؤال.
والله على راحتكم. انا كنت نرى في البدايه ان ناخذ الاسئله بعد كل شيء لان المغرب حيدخل علينا، فلو نعطوا يحيى فرصه يتكلم وبعدين عصام وبعدين ان شاء الله نتكلموا. دكتور رايس ولا يهمك ان شاء الله حنجاوبك على السؤال بتاعك، ودكتور هشام لو بس تستنى للنهايه نكملوا البرزنتيشنز وان شاء الله نتكلموا على الاسئله بتاعكم.
ممتاز. تفضل دكتور يحيى، الفلات is yours.
Yes. تسمع فيها؟
صوتك واضح.
Okay, شكرا. جزاكم الله خير. Thank you, Dr. Khalid, for this wonderful presentation. I'm gonna tackle the diagnostic part for the COVID-19, but before we're gonna go there, يعني comment لدكتور عبد النبي رايس. The FDA right now, they are in emergency settings. They are improving a lot of testing, as well as a lot of medications for the COVID with not strong scientific basis to start with. So not everything that FDA approved right now today, it's really gonna be existing for a while. Probably once we get over that period of time, inshallah, you're gonna see different. So just a quick review of our own experience in Washington, D.C. area. If we see the whole population here, around 30% will go asymptomatics. And this is the most dangerous part for, that we have, because these are people who are not gonna be quarantined, and they were not gonna be, and they're gonna be spreading the disease among the others. And the high-risk people that Dr. Khalid mentioned earlier, around 55%, we saw that there is between mild to moderate symptoms, and the severe cases are 10%, and a lot of them they will recover, and the critical are 5%. Our experience on those, if you go into the other end, you will see the 30% will none with them will go on asymptomatic and will be recovered. The mild to moderate symptoms, also the fatality rate is close to 0 or 0. Severe symptoms, the mortality rate is about 15%, and the critical symptoms, various, I saw that some of the hospitals that we have reporting about 30%, and others reporting up to 50% with increased morbidity. The symptoms, it takes about between 4 days up to 14 days to show, and we decide that we're not going to test any patient unless they are symptomatic. The reason is the number of testing is very limited in this country. I'm talking about USA, and we have to conserve those testing for the right purposes. And then we're gonna go later on into the immune, but I'm gonna leave this until we go to the plasma convalescence. Okay, Anwar, if you go to the second slide, please. Okay, so laboratory testing that we do see patients, and we look forward to see those patients. Most of the frequent result, and it's a little bit atypical than the normal viral pneumonia, is the reduce of lymphocytes, lymphocytopenia, and hypoalbuminemia. The hemoglobin will go down, C-reactive protein will go up, but C-reactive protein is very specific. SID rate will also gonna go out because of the inflammatory process, lactate dehydrogenase, and the D-dimer will go up. C-reactive protein, procalcitonin, and Dr. Khalid mentioned that. We are reserving this for the super infections due to bacterial infections. We will do that. Now, the other thing that we saw on the neutrophils and the severe cases, the neutrophilia, we increase the neutrophils, the liver enzymes will go up, and the cardiac enzyme will go up in case the myocarditis, and the procalcitonin for the super infections. Okay. And we'll go to the next slide. Do you have the next slide? Anwar, okay. So and this is the most important things here is the sensitivity of the testing that we do with the PCR is very important to know that it's the technique, the best way, the best out of the study that shows on the Chinese as well as Italian, the bronchial lavage fluid have a very high sensitivity to recover the virus, but not everyone will do it. So we're gonna go, we chose to do the nasopharyngeal, and if we can't get it from there, we also sometimes we do oropharyngeal swabs for these patients. But I noticed from my own experience, it's about the the technique of collecting the specimens. The better the technique, the better you recover of the specimen. Yes, we did see a negative, very few cases that they were negative at the beginning, and they later on they showed the positivity of the virus with the PCR. Now we're gonna we'll go into the other things is what we test. So the PCR, which is the nucleic acid amplification test for viral RNA. This is the way to test this methodology, test this disease. And there is several equipment out there. We do use the BD Max for the high volumes, and we do about maybe 100 tests every 4 hours with those tests. We also, Roche have the capability of doing this. In smaller hospitals, we do the QI-STAT and Gene Experts. They have the capability to do up to about 32 per hour. And the sensitivity is very good. The QI-STAT, we reserve this for the intensivist in case they are, or the babies, in case that they are questioning other viral involvement. So we have the COVID-19 as well as the upper respiratory viral panels, which contain influenza, parainfluenza, rhinovirus, retrovirus, all the others. The Hologic machine also just came out with massive testing, up to 500, I believe, in every 2 hours. So they are purchasing those for this area in case the number goes up. Okay, now in Europe, they are pushing for the IgG, IgM, and we choose not to use the IgG, IgM testing. One thing is we don't have the interpretations of the activity of the virus. So whether it is it's active viral, active infections or not. The other thing is the sensitivity for the IgG and IgM is very, it's not as good as I believe from our studies, it's about 40% sensitivity. So we chose not to proceed with that in this type of things. This is from the laboratory point of view. I believe I'm going to change from the clinical lab to the pathology that we do also. There's very few autopsy were performed on the COVID-19 patients, were performed predominantly accidentally in Oklahoma, state of Oklahoma, where they published those cases. Because those cases, the patient died without positive testing, but later on they confirmed the test post-mortem. And the finding of this disease is ARDS, acute respiratory distress syndrome. And they found, of course, the pathogenesis is taking those ARDS patients to multi-organ failure and to the death situations. The microscopic findings of these tests are diffuse alveolar damages due to the viral pneumonia, and because the thin part. So let's go back a little bit one more step before, which is don't worry about it. I'm moving away. Anwar, so thank you very much for that. The microscopic component. So the virus usually attach most of the mild cases attach themselves to the upper respiratory mucosa. The severe cases are the one that goes into the alveolar component, the lower part of the upper of the respiratory component, and they do induce the diffuse alveolar damages. The alveolar are the thin membranes that we have in the lung, and these are where the blood vessels comes and the red cells exchange the CO2 to pick up the O2, and the viruses are there where they invade the red blood cells and induce the microthrombi. That's what they found. A lot of the cases also studied from the Chinese as well as the European, Italian. Okay, some of those cases of the COVID, they found that these patients also have shown aspirated pneumonia and bacterial pneumonia also coexisting with the diffuse alveolar damages. So sometimes we have to pay attention that we are not only dealing with the COVID-19, but also these can lead to aspirated pneumonia as well as bacterial pneumonia, and that's where the procalcitonin play a role. 20 to 40% of the autopsies that were performed, they found that the microthrombi involving the lungs. And as a matter of fact, we do have a case existing in one of my two hospitals that the patient developed peripheral limbs gangrenes of predominantly 8 of her fingers show tip gangrenes, and they are performing, I think, amputation of those tips, I believe, this coming week. Okay, other than that, also we did see some evidence of myocarditis on those patients, and that's where the cardiac enzymes goes up extremely high with troponin I, and a few cases will show kidney damages. Most of the autopsy cases that performed on the brain did not show encephalitis, viral encephalitis, or any kind of encephalitis on those COVID patients. They usually show some thrombi, but very, very few of those cases. Okay, I'm gonna move into the third component of my talk, and which is the coalescence treatment. The coalescence treatment did start around 1890, so it's not very new. They used it in 1918 during the flu epidemic, and recently they use it also for the swine flu as well with Ebola. On those patients, we are hoping to recover some of the immunoglobulins in this plasma, and we are trying to transfer those passive immunity to the patients to help them fighting the disease. Now, we don't have the technology, the capability in this country to titer the immunoglobulins and to find out whether really the plasma that we are giving have enough immunoglobulin. As you know, the IgM will peak around day 4-6 of the exposure. The IgG will start peaking around day 10, but we're not gonna peak high. Usually it does not peak until the second exposure to the disease itself. So recovering those plasma from previously exposed patients, we hope that we are going to give this immunity to the patient. And it have to be also, as you know, we have to use blood specific. So if a patient is B positive, we're going to give it to B positive. If the patient's B negative, A negative, we'll give it to A negative. So we're trying to keep these factors right now. As Dr. Khalid mentioned, there are several centers. They are doing studies on the COVID. Mayo Clinic is one of the major centers. They're doing it, and they have protocols to follow, and this the protocol that we are following. I believe Johns Hopkins in this area also doing it. However, they have extend their study to give a plasma convalescence, to patients who are exposed but did not show the symptoms. So hoping that they will prevent the disease from beginning of that type of things. The side effect of plasma convalescence are usually immunological sides that allergic to transfusions. So we manage it on that and managing on that side. The dose of the plasma that we are recommending is between 200 to 400 cc. Usually in a good plasmapheresis, you should recover about close to 600 cc from a patient. So every patient you can recover about 2 to 3 units to give to 2 to 3 patients for that. And that's and as you guys know, that this disease did not hit this country until mid-February. And in the Washington D.C. area, we did not see the cases until early March. So the recommendations for the convalescents to be recovered from patients is either the patient have to be PCR negative or 28 days past the symptoms. And as Dr. Khalid mentioned earlier, that we're still seeing patients 6 weeks out and they still carry the virus by the PCR. And we still recommend those patients to keep their mask on, but they can go out and participate. We have about, at least in one of the hospitals, I have about 3 physicians that they expose, or 4 physicians actually. Yesterday, we have another physician, intensive care doctor who conducted the virus. So it's very, very important that we have to keep the PPE on those cases on that. So we chose to go with the 28 days post symptoms to or breaking of the fever to encourage those patients to donate their plasma for convalescence transfusions. Okay, any questions from my side? Dr. Khalid? دكتور خالد.
ايوه دكتور يحيى، شكرا جزيلا لك على المعلومات القيمه. We should proceed directly to Dr. Isam and come back for questions. دكتور عبد النبي رايس عنده شويه اسئله وكذلك دكتور هشام، لكن خلينا نتوكل على الله نمشي الدكتور عصام وبعدين نرجع مع الاسئله. تفضل دكتور عصام. دكتور عصام. Maybe Dr. Isam is muted. Anwar, Dr. Isam.
نعم أخي نعم. I was unmuted. I mean, I was muted. That's why I couldn't. Can they unmute the camera also, please?
Anwar.
Okay, I think I'm good now. Are we good? Can you hear me أخي خالد؟
صوتك واضح جدا. تفضل دكتور عصام.
تمام الله يسلمك. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Once again, thank you very much for the event. I will first just introduce myself. My name is Dr. عصام عميش, طبيب جراح في منطقة واشنطن عضو طبعا حاصل على البورد الأمريكي، وكذلك زميل في جمعية الجراحين الأمريكيين American College of Surgeons. Today I'm going to be talking about the surgical precautions and COVID-19 pandemic. Part of this discussion is a little bit off the main topics that were presented earlier, but it's also important because as surgeons, we deal with these patients in the hospital. I just did a tracheostomy on a COVID positive patient yesterday, and it's something that we see every day. And I think it's very important that we create the environment and the know-how for our surgeons so that they can, inshallah, take care of the problems at hand without any problem. So let me just see if I can. I'll take next slide. طبعا انا حخلط بين العربي والانجليزي الحقيقه، حتى لان اتوقع الحضور كله بالعربي. يعني اهميه هذا العرض يا اخوه هو موضوع اعطاء الجراحين القدر الكافي من المعلومات والقدر الكافي من المعدات حتى يعني نستطيع ان نغطي جانب الجراحه في المستشفيات بدون تعرضنا لاي مشاكل. والحقيقه اطباء الامراض المعديه واطباء التنفس والتخدير والاي سي يوز والانتنسيف كير وغيرها هم يعني اصحاب التعرض المباشر للمشكله، فهم خبرتهم يعني يجب ايضا ان تنقل الى الاطباء الجراحين. طبعا هذه الصوره عباره عن صورتي على اليسار انا، اللي هو قبل عمليه التريكياستومي. عملتها طبعا في مازال اضافات يعني الجلافز والغطاء الرجل واللبس طبعا المستشفى وغيرها، بس الهود هذه هي الان اصبحت جزء من المعدات، بالاضافه الى الريسبيريتر اللي هو الN95 اذا تعرضنا الى مريض عنده الاصابه ويعني واضح جدا انه طبعا هو مصاب بالمرض. الجهاز ايضا فيه نوع من التهويه الداخليه الحقيقه لاعانه الجراح للقيام بالعمليه. نكست سلايد. طبعا هذه نفس هذه الصوره مقربه منها. نكست سلايد. فأنا اليوم حتكلم على خطوط عامة هي متفق عليها من American College of Surgeons. These are standards and this is what we are implementing across المستشفيات عندنا في أمريكا. Next slide. الأساس the considerations that we're doing يعني هي القضية بالنسبة للجراح كيف يتم إعداد المريض ما قبل العملية، خلال العملية، وما بعد العملية. طبعا هذا جهد يعني أكبر بكثير من أنه هو جهد فقط محدود بالعملية نفسها. حتى إحضار المريض من غرفة العناية المركزة مثلا لغرفة العمليات يحتاج احتياطات يجب أن تكون موجودة في داخل النظام الصحي اللي هو مستخدم، سواء طريق يحدد يخصص تحديدا لنقل المريض. مرة احنا نستخدمه في باك اليفيتر مخصص فقط لهذه. لما يوصل على غرفة العمليات عندنا ممر مخصص فقط لمرضى الكوفيد، منها يدخلوا الى منطقه زي ما تكون احتياطيه بين غرفه العمليات وبين غرفه العمليات نفسها. فهذه المنطقه يتم فيها ايضا بعض الاعدادات اللي هي تعين الممرضات او الممرضين وتعين الستاف نفسه انه كيف يتعامل مع غرفه العمليات. بعدين ندخل على غرفه العمليات. غرفه العمليات نفسها غرفه فيها نيجاتيف بريشر، الان فيها الضغط السالب اللي هو يعمل على عدم توفر الجراثيم مثلا في الهواء لفتره معينه. المعدات اللي هي موجوده داخل غرفه العمليات كلها مجهزه بطريقه انها مغطاه باغطيه مفتوح منها فقط الجهات اللي هي نحتاج منها مثلا توصيل الانابيب، نحتاج منها فقط ادخال مثلا الخيوط الكهربائيه، غيرها اي اعداد لابوراسكوبي ما غيرها، كلها مغطاه بحيث انها حتستخدم. هي غرفه واحده مخصصه. احنا عندنا مثلا غرفه عمليات، عندنا 20 غرفه عمليات في المستشفى اللي فيها، واحده منهم مخصصه الان للتعامل مع حالات الكوفيد نفسها. فانا بودي ان ناخذكم ان شاء الله خطوه خطوه في قضيه انه ايش الاقسام اللي احنا نحتاج انه نهتم بها في غرفه العمليات كغرفه عمليات متكامله، والاشياء الاساسيه اللي لازم يعرفها الجراح. طبعا اساسها هو استخدام المعدات الحاميه، البيرسونال بروتكتيف اكويبمنت، الPPE. في بعدين موضوع التعامل مع الجراح وطبيب التخدير، وغدا ان شاء الله حيكون معنا الدكتور يوسف العاجلي حيتكلم عن اشياء محدده لها علاقه بموضوع التخدير والاشياء اللي ممكن تستخدم فيه من اجل الحمايه في الانتبيشن، لانه فيها اكسبوجر للايروسولز وللهواء وغيرها، ففيها مهمه. بالنسبه للجراحه ايضا تحديدا في بعض القضايا اللي لها علاقه بالعمليه الجراحيه تحديدا، وبعدين كيف العمليه يصير فيها بعد ما نكمل العمليه، كيف ناخذ المريض، كيف نتخلصوا من الاشياء اللي استخدمت، كيف يكون، وبعدين يعني بعض الاشياء الاخرى اللي قد تكون فيها اهميه. انا حطيت بعض الدايجرامز وغيرها بحيث انها تبقى كريسورس للاخوه الافاضل في ليبيا. تفضل نكست سلايد. بالنسبه للمعدات الشخصيه، يعني بدون شك واحده من اهم الاشياء اللي هي اذا اردنا الاطباء ان يقوموا بدورهم بشكل عال يجب ان تتوفر لهم المعدات. فانا ارجو الحقيقه من الدكتور الفاضل عبد النبي الرايس والاخوه الافاضل الموجودين معنا ان يولوا هذا الجانب الاهتمام الكثير. احنا سمعنا ببعض المشاكل في ليبيا من عدم رغبه بعض المستشفيات العامه حتى والاطباء من استقبال المرضى بسبب تخوفات وغيرها. كل ما احنا ازلنا المخاوف هذه، وكل ما احنا وفرنا المواد اللي نحتاجها من اجل حمايه الطاقم الطبي سواء كان الطبيب او الممرض او حتى المساعد، يعني كل ما كان القدره على التعامل مع المشكله هذه اسهل بكثير. فبالنسبه للكمامات اللي هي مخصصه N95 respirators او ما اكثر، هذه بالنسبه للتعامل مع اي مريض فيه عند طبعا الكوفيد لازم تكون موجوده. الاطباء اللي ممكن عندهم لحى او لم يتوفر لهم عمل اللي هو الفيت تيستنج اللي هو الترتيب الكامل لوضع الماسك، يحتاجوا ان يستخدموا هذه اللي احنا نسميها سبيس سوت، يعني البدله الفضائيه هذه اللي وريتها لكم في البدايه، نحتاجها في اجهزه معينه ترتبط معها بتوفر تهويه داخليه تخليها مريحه جدا. يعني الحقيقه قمت بعده عمليات بها وكانت مريحه جدا وما كانش في اي مشكله من الناحيه الجراحيه. طبعا القضايا استخدام الاشياء اللي انت تستخدمها، كل حاجه تمسها لازم تتلوح يعني في الغرفه نفسها قبل ما تطلع، الا هذه اللبسه هذه طبعا لانها مكلفه فتمسح يعني بكلوراكس وغيرها بحيث انها تكون جاهزه للعمليه اللي هي بعدها. موضوع الغسل اليدين وغيرها هذه كلها قضايا معروفه. مهم جدا تدريب الناس في قضيه كيف لبس الاشياء هذه بطريقه، طبعا في اللبس سهله لكن كيف انها تنشال بطريقه معقمه ايضا. يعني محتاجين الحقيقه شويه جهد يبذل بتدريب الطواقم وتدريب الستاف كيف يعرفوا يلبسوها وينحوها بحيث انه ما يكونش في اي تلامس، يعني لا قدر الله يزيد من مشكله الاشكال هذا. نكست سلايد. طبعا هذه سلايد فيها جود ران داون بالنسبه لايش البي بي اي المطلوب في ضمن الحاله اللي هي مستخدمه، فاتوقع انها كويسه لانه في اضافات. طبعا اذا انت تاكدت او في شك كبير انه المريض عنده الكوفيد 19 فلا بد من لبس حمايه الوجه، لا بد من لبس اشياء تغطي العين وتغطي الجوانب اللي هي حوالين العين بحيث انها تكون كلها محميه بحيث ما يكونش في احتمال. طبعا الجاونز، اللبس الدبل جلافينج اللي هو انك تلبس اكثر من جوانتي يعني او قفاز. نكست. بالنسبه للفكره اساسا، يعني شوف احنا مرات ما كتر تخوفنا من الكوفيد وغيرها نفقد قدرتنا على بس التفكير البسيط يعني او التفكير المنظم خلينا نقول. هي الفكره اساسا انك انت تتعامل مع فيروس شديد العدوى، فانت كجراح او انت يعني انسان تتعامل مع الواقع الطبي يهمك بس انك انت تاخذ الاحتياطات اللي انت فاهمها واللي انت عارفها بمستوى اعلى المستويات. فحتى موضوع مثلا الانتبيشن بالنسبه لجماعه الانستيجيا، الخوف طبعا من حركه الهواء خلال مثلا عمليه التنبيب او وضع الانبوب في القصبه الهوائيه. فاي حاجه لها علاقه بالعمليات اللي ممكن فيها اكسبوجر كبير يجب ان تؤخذ بعين الاعتبار بشكل مهم جدا. موضوع الانتبيشن بالنسبه لجماعه التخدير، موضوعنا احنا كجراحين بالنسبه لمثلا التريكياستمي وضع الانبوب في القصبه الهوائيه، موضوع الاندوسكوبي بالمناظير مهم. احنا لما نعمل لابوروسكوبي اللي هي جراحه المناظير هذه نحتاج انه احنا نهتم بقضيه الهواء الذي يخرج من بطن المريض او الهواء الذي يعني يكون في المحيط مثلا من حرق. لما نستخدم الكوتري والاشياء اللي هي فيها لازم تكون معها انابيب متصله بحيث تمتص الهواء. فموضوع الاهتمام انه البادي فلويدز، الاسبريشن، الاير كله يكون اشياء مهمه جدا. من الاشياء البسيطه ايضا حال وضع الانبوبه التنفس في المريض كله يكون برا الغرفه الا طبيب التخدير ومساعده، بحيث انه نقلل فتره الاكسبوجر نفسها، حتى الستاف نفسه يكون خارج الغرفه. موضوع النيجاتيف بريشر اوبريتنج رومز والانتي رومز، الانتي رومز اللي هم الغرف اللي تكون مجاوره لها يتم اعدادها بطريقه بحيث احنا عندنا مثلا في العمليات اللي قمت فيها الممرضه اللي تقدم لنا المعدات سواء السوتشرز او التريك بيس او اي حاجه نطلبها هنا في الغرفه ما تخشش الغرفه، يكون في بينها وبين الممرضه اللي داخل طريقه لاستلام المعدات والقيام بالمطلوب. كلها اجين اشياء احنا نقوم فيها او نقدر نفكر فيها، لكن لازم نحطها في نظام يتعود عليه الجميع بحيث انه ما يصيرش في خلل يؤدي الى لا قدر الله الضرر بالاخرين. نكست سلايد. بالنسبه طبعا داخل غرفه العمليات كما ذكرت كل الكوتر اللي هي نستخدم فيها طبعا كثير احنا في العمليات اللي هي القلم الكهربائي اللي نستخدمه فيها، يجب ان يكون الان الانواع اللي نستخدم فيها ستاندرد اكروس ذا بورد الان هي اللي متصله بنظام يعمل على مص الهواء اللي هو يخرج من الحرق نفسه او من الاداه نفسها اللي تستخدم. موضوع اللابوراسكوبي يعني يستخدم معه الاحتياط اللي يستخدم في الخوف من اي التهاب داخل البطن. فموضوع الفتح مثلا الهواء او امتصاص الهواء من داخل البطن وغيرها يجب ان يتم بطرق معينه، وهناك الان اجهزه متخصصه في ذلك. تريكياستومي تكلمنا عليها. نكست بليز. بالنسبه لبعد العمليه كما ذكرت فيما يتعلق بنقل المريض، فيما يتعلق بتخلص من المعدات، فيما يتعلق ب زي ما تقول حمايه المريض او عفوا حمايه الطبيب الجراح او غيره داخل الغرفه. هنالك سلايد كبيره تو ان شاء الله تكون متوفره حتى هي تستخدم مره اخرى لوضع نظام نستطيع من خلاله الاستفاده من الخطوات اللي هي مترابطه ببعض اللي تمنع حدوث المشكله. نكست سلايد. طبعا انت يعني في النهايه انت بشر، وكل طبيب منا او كل انسان مشارك في عمليه وغيرها عنده اهله، خاف على نفسه خاف على اهله. فحتى القضايا البسيطه اللي هي يعني زي ما تقول كيف انت بعدين بعد ما تخلص وجودك مع مريض فيه عنده الكوفيد او عنده الفيروس وتعاملت معه وتعاملت مع سوائل جسمه او غيره كيف انك انت تاخذ خطوات ايضا تعين نفسك بانك انت تحمي نفسك وتحمي من حولك الحقيقه. فايضا في بعض الريكومنديشنز في هذا الامر، جزء منها يتعلق بمسح كل الاسطح اللي تعرضت لها يعني اللي ممكن يتعرض لها الفيروس في وجودك هناك، استخدام بعض الاشياء المعقمه في تعقيم حتى اشيائك الخاصه اذا كانت انت يعني قريب منها او كنت لما تغير حوايجك. طبعا موضوع انك انت الملابس اللي انت عملت بها العمليه تتخلص منها كامله، تعمل شيء محدود للعدد الاشياء اللي انت تحضرها من الخارج وتاخذها معك للبيت. احنا عندنا مثلا انا شخصيا في البيت عندي مثلا مدخل ادخل منه، بعدين اول ما ادخل منه اتخلص مثلا من الاشياء اللي هي زي الحذاء وزي غيرها خارج المنزل، ادخل مباشره على الشاور اتاكد انه اخذ يعني شاور. ديسانفكتنس موجوده دائما في استخدامنا سواء في مسح الاسطح او سواء في مسح الايدي. نكست سلايد. هذه جود. حاجه ثانيه بالنسبه للجراحه ايضا موضوع توقيف العمليات او القيام بالعمليات المطلوبه. يعني في النهايه احنا اوقفنا العشرات من العمليات بالنسبه لي عندي مثلا في البرايفت براكتس بتاعي وغيرها لانها الكتيف سيرجري. فموضوع احنا الان as of May 1st يعني امبارح القوانين الموجوده اللي هي الضابطه لنا في ولايه فرجينيا اقرت انه الان نستطيع ان نبدا ان نقوم بالعمليات اللي هي الالكتيف سيرجري. طبعا ماريلاند مثلا على سبيل المثال هي الولايه المجاوره لنا يقولوا لهم انه 15 يوم ثانيات، يعني ما زال اسبوعين ثانيات حسب ظروف الولايه وحسب عدد الاصابات وحسب وين في المسار البياني اللي هي موجود فيها. فارجو من الاخوه القائمين سواء في المركز الطبي للامراض او بعض المستشفيات الاقسام الكبيره يبدو يدرسوا السياسات هذه حتى يعرفوا كيف يتعاملوا مع المصحات والمستوصفات اللي تقوم بعمليات الان، غرف الولاده، الناس اللي هي زي ما تقول ما زالت ممكن تعمل في اعمال او اللي هي شت داون حتى. يعني انت في النهايه في ضرر يترتب على عدم القيام بالعمليات المطلوبه في الوقت المطلوب. فالبدايه كيف تكون حتى هي احنا بدانا في وضع الجوريثم معين، يعني نظام معين انه الحالات اللي هي طبعا الحالات الضروريه، انا طبيب جراحه طوارئ ايضا يعني، فانا اليوم انا طالع بعد من هنا عندي عمليتين لازم اعملهم الان. فدائما وضعنا احنا في يعني العمليات الطارئه هذه مع كل الاحتياطات المطلوبه، لكن العمليات اللي هي يعني مثلا مريض عنده احجار تسبب له في الام بالنسبه للمراره، ياتيني لكن هو مش مصاب بحاله ازمه سريعه. احنا في الفتره اللي فاتت كنا ناخرهم شويه، نقول لهم يعني يستنى الا لا قدر الله لو صارت ازمه كبيره. الان حنبدا نحطهم في الجدول، لانه العمليات اللي زي هذه كل ما استنيت عليها كل ما احتماليه المرض او احتماليه الخطر تزيد. فالان بدانا في تسهيل هذه الامور. بالنسبه للالكتيف اللي هو مثلا زي توتال نيز او العمليات اللي هي ممكن الواحد حتى يستنى عليها اشهر او غيرها وغيرها، بدانا نخفف الضوابط، ولكن اذا الجدول العمليات يعني ما كانش يسمح باضافه هذه العمليات فما عندناش مشكله، حنستنى عليهم. بينما اللي هم سماي الكتيف اللي عندهم سم سنس اوف ايرجنسي بدانا فعليا نسجل. انا يعني وضعت 5 أو 6 عمليات يعني ماندي لانه بدانا خلاص احنا فعلا في تسريح هذه القضيه. هذه البروسيجرز او هذه الانظمه يجب من الان نبدا نحطها فيها ونشجع يعني الناس للالتزام بها، وفي نفس الوقت الحوار عنها. يعني خلينا نكون عندنا فريق من الجراحين الخبراء يعني يجلسوا مع بعض ويناقشوا مثلا افضل الوسائل لتنفيذ هذه الامور. هذه الامور العمليه اللي هي حتمس الحقيقه اطبائنا وحتمس الناس اللي هم يحتاجوا عمليات وناسنا وغيره يعني. ففي وجود احيانا الخوف ووجود عدم الوضوح، احيانا التطبيقات هذه قد لا تطبق بالطريقه المناسبه، لكن يجب ان نستعد ونبدا في هذا العمل. وان شاء الله في ليبيا المسار البياني يصل الى مرحله فيها تسطيح كافي يعين على الفتح يعني المتدرج حتى يتم ان شاء الله العمل المطلوب. نكست سلايد. بالنسبه هذه وجدتها يعني ممكن احنا من اجل الوقت انا ممكن ما اطول فيها، بس هذه يعني مثلا خذوها كمثال مثلا اللي هي مثلا احنا في عمليه التريكيوستومي اللي هي العمليه اللي فتح يعني في القصبه الهوائيه. لو تشوف مثلا الستاندرد اوبراتيف بروسيجر for a case like this for tracheostomy in a COVID-19 positive patient, you will see steps that are again you probably know it offhand, لكن you need to do it in order. فموضوع البريباريشن، موضوع الجاونينج، موضوع استخدام ال N95 mask، موضوع الاي and face protection that must be worn at performing the tracheostomy نفسها، موضوع الانتجريشن of all these options. الله يسلم انا مثلا I was never fitted، ما كنتش راغب اني احلق لحيتي الحقيقه، فغيروا لي لقضيه هذه الهود اللي هي ايرسولايزد او اللي هي فنتد هود. ففي موجوده موضوع الجاونز نفسهم، مش كل الجاونز مغطاه بطريقه انه تمنع دخول السائل داخل الغطاء الخارجي، فمعناتها لبس حاجه تحتها اللي هي من النايلو او شيء اللي هي تعينها تصبح فلويد ريزيستنت مطلوبه. الجلوفز انا نورمالي اي نيفر دبل جلوف even though it's يعني I always wear just one glove، لكن مع كل كوفيد بيشنت I'm double gloving, I'm using يعني more careful techniques. next. فلما تشوف مثلا تحديدا في التريكيوستومي، حتى التريكيوستومي التوب نفسها في عندنا خيارات، احنا مرات نستخدموها ببالون في اخرها، مرات بنستخدموها من غير بالون. هنا لا، احنا everybody has to be cuffed tracheostomy لانه الاير that goes around the tube can cause the virus to spread. موضوع ان انت حتى يعني زي ما قلت لك تغييرات حتى في البروسيجر نفسها، يعني لما نفتح القصبه الهوائيه اول حاجه نديرها نطلب منهم انه ينزلوا البالون، لانه نبيهم يحركوا الانبوب بحيث ان نحط الانبوب بتاعي اللي بنحطها. حتى هذا في حد ذاته الان نقول لهم لا، خلي الانبوب فوق، حرك الانبوب من غير ما تنحيها، فتجد نفسك. موضوع الفنتيليشن، وانين نفتح في القصبه الهوائيه باش نحط الانبوب نطلب منهم انه لمده يعني 30 ثانيه او غيرها ما يقعدوش يديروا فنتيليشن، لانه هو يدير في الفنتيليشن هو يدفع في الهواء من خارج الفتحه الموجوده في القصبه الهوائيه في وجهي، وقس على ذلك. يعني هذه اشياء مهمه. في الان حتى في استخدام شيء بيسموه هيت اند مويستشر اكسشينجر، قطعه تضاف الى الانبوب نفسه اللي هي تعين في تطهير او يعني تعين في التخلص من احتماليه يعني مثلا وجود الفيروس واشياء من هذا النوع. فالنقطه اللي اريد ان يعني اشير اليها من هذا العرض هو انه الان نحتاج ان نضع كل الخبرات اللي عندنا والتفكير اللي عندنا كيف نطبقه في عملياتنا، سواء كانت فتح بطون، ازاله قولون، ازاله معده، او سواء كانت في اندوسكوبي او غيرها. طبعا كل واحده لها درجات، لكن في النهايه هي منظومه تفكير تصبح طريقه عمل الجراح. نكست سلايد. هذه كويسه بالنسبه للمانجمنت اوف ذا او ار كيسز. يعني ارجو من الاخوه الافاضل مره اخرى والاخوات الفاضلات يعني في ليبيا، موضوع انك كيف تاخذ فريقك انت، فريق الجراحه نفسه، عندك ممرضه اللي هي نيرس ان تشارج، او عندك الشخص اللي يعينك في تصريف الامور في غرفه العمليات، عندك الممرضه اللي هي في غرفه العمليات، عندك فريق التخدير، عندك التكنيشنز او التقنيين اللي هم موجود معك في الغرفه، بالاضافه الى انك انت جراح وبالاضافه الى مساعدك. كل واحد يلعب دور لنجاح العمليه هذه. يعني انا العمليه المره اللي فاتت عاده تاخذني 30 دقيقه باش نديرها، الاعداد لوحده تقريبا اخذ ساعه ونص من انتظار لجلب المريض لوضع الغرفه الخروج منها لغيرها. يعني كل مجمل الوقت اخذ تقريبا كما ذكرت ساعه ونص داخل غرفه العمليات، وممكن ساعه اضافيه بين المساعدات وبين الترتيبات وبين غيرها. فجهز نفسك، حط نفسك لهذا الاطار، خلي غرفه العمليات محدده، جهز لها الطريق غيرها. بالطرق هذه نستطيع انه ان شاء الله نتغلب على كل التحديات. والحقيقه يعني من التجربه الان المباشره في هذا الامر، انا اعتقد انه الحمد لله يعني سواء للجراح وسواء للطاقم الطبي الامور كانت ممتازه جدا، وكانت فيها حمايه كامله للطاقم الطبي، بالاضافه الى الرعايه المطلوبه بكل ما فيها. يعني لا تجنبنا نعمل عمليه للمريض، ولا كنا خايفين من التعامل مع المريض، ولا الحمد لله كان في اي كسر او اي خرق لاي منظومه داخل العمليه نفسها لما انتهت، وكان اداء ممتاز جدا من كل الاطراف. نكست سلايد. نتوقع ان هذه اخرتها. فحقيقه مره ثانيه ارجو الاهتمام بالطاقم الطبي الجراحي، وارجو كذلك الاهتمام بتحقيق نوع من الطمانينه والتوعيه عند الفريق الجراحي ككل، لان هذا حيعين ليس فقط على التعامل المباشر مع مريض الكوفيد واعطائه الرعايه الصحيه المطلوبه، ولكن ايضا يعين في التعامل مع التخوفات اللي موجوده داخل نظام الجراحه ككل، بسبب طبعا وجود المرض، وبسبب احتماليه لا قدر الله وجود اي مريض ياتي عندك. اخر حاجه نقولها، انا اليوم مثلا كما ذكرت عندي عمليات، الحقيقه مريض عنده زائده ومريض ثاني عنده مراره، لكن كل واحد منهم درنا له الكوفيد تيست. يعني اصبحت الان بوليسي انه ما يدخل مريض عندنا في غرفه العمليات الا والكوفيد تيست ينعمل له. بعدين طبعا اذا نيجاتيف ندخل احنا في اطار الاستعداد العادي اللي نقوم به، اذا كان بوزيتيف لا قدر الله ندخل في تفعيل كما ذكرت المنظومه اللي موجوده داخل غرفه العمليات. حفظ الله ليبيا، بارك الله فيكم، رمضانكم مبارك. احنا قربنا عليكم في وقت الافطار، وارجو ان شاء الله ان تتحقق الاستفاده وان نتواصل مره اخرى. شكرا لكم.
شكرا جزيلا لك دكتور عصام، بارك الله فيك. طبعا تكاتف الجهود هو واحد من الاسباب الحقيقيه لنجاح العمل الطبي. العمل بروح فريق العمل، هو هذه أسباب حقيقية الحق محتاجين نخدم عليها في ليبيا كثيرا، لأن هذه هي اللي بتخلي المريض أول شيء يكون مرتاح، وفي نفس الوقت النظام الصحي يمشي بطريقة مضبوطة. ربي إن شاء الله يوفق الجميع. في كثير من الأسئلة، أنا بفضل أن الدكتور عبد النبيل رايس يطرح عنده 3 أسئلة تقريبا، الدكتور هشام القبلاوي عنده تقريبا سؤال. الدكتور عبد النبيل موجود معنا، تفضل تطرح الأسئلة بتاعك مباشرة، وبعدها دكتور هشام. أنوار if you can unmute everybody، وخلينا نرتب الناس اللي تتكلم. تفضل دكتور خالد.
لكن تو الناس
نعم تفضلي أنوار.
I was going to say لو تبوا تفتحوا صوتكم.
تمام. دكتور عبد النبيل لو سمحت الأسئلة متاعك هم جو متفرقات مع بعضهم، لو كنت تتفضل بيهم.
بارك الله فيكم، مشكورين جدا، محاضرات رائعة جدا واستفدنا منها. سؤالي نبدأ من الأخير، الدكتور عصام تقريبا أخير عميش. It could be a silly question, but curiosity. Coronavirus can be transmitted percutaneously from patients' blood or secretions. هو غير يعني مجرد فضول بس. هذا السؤال الأول. تعليق على حالاتنا اللي توفوا، حالتين الزوز اللي توفوا عندنا في المستشفى، واحدة منهم الأولى هذه عمرها 66 سنة. I think she was having some type of system sclerosis, taking steroids. فهي she had a very good smooth evolution of her condition، ومتوقعين أنه كنا نطلعها وفرحانين بتطور الحالة للأحسن، لكن صادر لي she had arrhythmia حسب ما حكوا لي الزملاء، ويا ريت الدكتور عبد الرؤوف موجود معنا في المجموعة، تقريبا هو كان حاضرها يزيد يعقب على الموضوع. الحالة الثانية حتى قريبتها أكبر منها في السن 91 سنة. حتى she had a very smooth evolution. No one of them had pulmonary problems per se, just mild respiratory complaints. اللي سبب الوفاة كان looks to be some type of heart attack or some embolism. للأسف الثانية هذه كانت دايمر increasing زادوا لها جماعه حد دوز نتاع التريتمنت فور pulmonary embolism وشي died. She had very bad bradycardia. She was submitted for resuscitation and she passed away. تعليق بسيط جدا غير مجرد قارنوا بين حالاتنا والحالات اللي تشوف فيهم انتم اكثر، الله يبارك عندكم حالات كثيره. just to give us an opinion. فيها بالنسبه للتحليلات دكتور التاجوري تقريبا مشكور على المحاضره القيمه. سمعت ان في تقريبا سيلكس شركه اسمها سيلكس or something like that. She had a test which is highly sensitive, highly specific و uses IgM, IgG. وتقريبا مش متأكد من الموضوع هذا لكن I would like to know whether it includes antigen in this test. فأنا بتعليق الدكتور التاجوري. بنفكر الزوا الميتينج حيكون في الليل إن شاء الله، مش في العشية، من 10 في الليل. آخر سؤال. Neutrophilia as noted by Dr. Tajuri goes up due to secondary bacterial infection. سامحوني لو سؤال كان بالغلط، هو just الcorrection بتاع النقالي غلط في وضع الكلمة. Neutrophilia which comes in the late phase, is it due to secondary bacterial infection or makes part of the COVID-19 itself? تقريبا هذه هم الأسئلة اللي نبي نبعثهم، ومشكورين جدا. بارك الله فيكم دكاترة، والله ما شاء الله يعني استفدنا كثير.
دكتور عصام،
مشكورين.
دكتور عصام تفضل بالإجابة بعدين.
على السريع. طبعا بدون شك الريسبيراتوري والالفيلر يعني لافاج وغيرها هذه هي اللي فيها اكثر السبيسيمن، لكن واقع الحال الحقيقه في دراسات يعني الان لديتكتنج الفيروس في اليورين وفي البلد وفي الستول. موضوع انه كم يبقى او قداش ممكن كيف ممكن يأثر على viable يعني يكون infectious material في الكوفيد. I don't know that we have clear guidelines في الموضوع هذا، لكن الاسsumption is there لانه technically it was detected there. وفي بعض الدراسات اللي لها علاقه بالميرز اللي هي الحالات اللي سبقت في البانديميكس الاولى إنها موجوده، لكن واضح جدا طبعا انه it's respiratory. الايروسوليزيشن اللي هي موضوع تدخل الفيروس في السائل نفسه خطير جدا في الممرات اللي هي الهوائيه واللعاب والرقبه وغيرها، لكن كما ذكرت السوائل الاخرى وجد فيها، ولذلك الجراح اللي هو يتعامل الله يكرمك مثلا مع الدم ومع البول اذا كان مسالك او غيرها، انا اعتقد انه الاحتياطات يجب ان تؤخذ بكاملها على اساس انه موجود فيها الفيروس واحتماليه النقل موجوده، لكن الاثبات بانه 100% على ما اعرف لا، ولعل الدكتور يحيى يكون عنده بحكم انه باثولوجيست ممكن يكون عنده معلومات اكثر. والله اعلم.
دكتور عصام هو مشكور جدا على الاجابه، لكن نقصد هل انتم بيناتكم هيك كجراحين لما بتخشوا العمليه كان عندكم خوف انه من needle stick injury as a way to transmit the infection؟ just يعني فضول بس يا دكتور.
انا I would the answer is yes لانه شوف حتى موضوع
الكود كل السوائل هو موجود كل السوائل فعلا يعني او اغلب سوائل.
صحيح.
معلش عصام معلش. Viremia is not recorded in the COVID-19. Viremia, which is the virus in the blood, is not recorded in the COVID-19. It might it's recorded in other viral infections, but not in COVID-19 so far, from my understanding from the Chinese, Italian, and the French studies, as well as in New York. Okay, now I know that even in our system we discuss like receiving tissue, a viral tissue before fixations, how to handle those cases. Some I disagree with them, but some of them they went into extreme where they say no, we need to fix those tissue in formalin for about a week before we touch it. I disagree because again here, viremia is not a part of the COVID. Now, number two is most of the tissue that received, unless as Dr. Khalid earlier said, the droplet. There is macro droplet in the Japanese study. There is macro droplet that 80% of them will drop down into the ground within about 4 to 5 feet. The micro droplet is the problem that you can carry carry, because the microglobulet can go as far as meters, 10 meters across the room they found. So these are the infection particles that you're really worried about. If those microdroplets have, if those droplets had attached themselves to a limb or to the external surface where they did not really desensitize before the surgery, then yes, I have to worry about it.
دكتور يحيى
We
في
have
سؤال
to take the precautions for that.
في سؤال ثاني يتكلم عن نيوتروفيليا.
Okay, okay. So the COVID pneumonia, or the pneumonia developed from the COVID, it's an atypical ARDS. It's not a typical ARDS that you can see it in influenza or parainfluenza or any other viral infections. It's an atypical one. So the atypical and the one that we saw is the opposite of the neutrophil and the lymphocytes. And it's not because of the bacterial infections. Yes, some of the autopsies that they found that those patients develop also aspirated pneumonia and bacterial pneumonia beside the COVID pneumonia, but the early ones that is pure COVID infections, the neutrophils was up, the lymphocytes were down, and it's becoming part of the atypical ARDS pictures that we saw in on the COVID.
شكرا.
Okay, now the third question.
تفضل يحيى عندك مثال ما تضيف تفضل.
Yes, the third question انت سألتني عليها اللي هي the machines او that. لو جي مثلا على ليبيا، اوكي مثلا في اوروبا they start moving from the PCR testing to the IgG IgM testing. Okay, the problem here معنا في أمريكا, we did not know what to interpret IgG IgM. For example, the influenza H1N1, the swine flu or avian flu, okay, that we saw, okay, it's very quick spreading. Like you're next to the patient, you develop the symptoms the next day. This patient, that he can develop the IgM, but he's not asymptomatic, and they are carrying it for about 14 days before they show the symptoms. So what are you going to do with the IgM? What are you going to do with the IgG? Okay. The problem here is, are you going to quarantine those patients? Okay. Or you are going to, oh yes, your IgG is high, you can go now, you're immune. Okay. So the infectious component of the disease versus the immunoglobulin component made us choose to go with the PCR as the testing component and not with IgG, IgM. Now, the European studies, okay, they start showing that, oh, you know what, I have too many cases, I don't have enough testing for the IgG, I'm sorry, for the PCR, and it takes a while for it, okay, so I'm gonna shift to IgM, IgG as a way to proceed with those patients. So that's where they have the other thing, Abdelmi, you have to understand that there is a business component of that testing. So a lot of companies will push their component as يعني حتى أعتقد في بداية تعليقك قلت إن بعض شركات الأدوية والأدوات الطبية أصبحوا يستغلوا الموقف هذا كموقف تجاري, and they proceed to push their own equipment. And the FDA right now have a big problem controlling those with the publicity out there and the pushing of the White House out there. So it start moving a lot of those testing in emergency status without really a good study. For example, حتى الدكتور خالد حكى عليها اللي هي hydroxychloroquine. Okay, hydroxychloroquine. Okay, the initial study from France, okay, was based on 20 cases, and there was no control case that came with that with a study. So, and some of those cases dropped from the study. Some of them ended in the ICU. So there was no really clear study. The New England Journal studies that came out about 2 weeks ago, it have bigger populations, it have a control populations, and did not show really a good outcome of those cases. Although some of the comment that came out in those the hydroxychloroquine in the early times, early stage might have benefit, like in the late stage, it really did not do any benefit on for those patients. And that's why a lot of hospitals, at least in this area, they start dropping the hydroxychloroquine on that type of things.
شكرا دكتور يحيى.
I have to add one thing. We do have a lot of Indian friends, physicians, that they are taking hydroxychloroquine as prophylaxis, which is, I disagree with that, but that's their territory. Thanks.
شكرا. دكتور خالد عندك تعليق ولا نمشي الدكتور هشام القبلاوي؟
السؤال كان في الأول بكرة من دكتور عبد الدنبي، هو بمسألة التريتمنت. Let me, if I can put my, في كيف نحط البرزنتيشن تاعي بالمعاود.
Yeah, just do the same thing. You can just share your screen.
How about now? Yeah, you see it?
No. You go to the bottom, share screen.
Okay, never mind. I mean, so the remdesivir, the way it works on the RDRP, which is the polymerase that when I showed you earlier, either with fusion or endocytosis, the viron gets in, it gets broken up, and then it reassembles again. So the remdesivir acts on that stage, the reassembling, it blocks it. It is not FDA approved yet. It is only released for emergent use. It is given right now for courtesy only. It's not even widespread. In my hospital, we don't have it. Mohammed Turkey, they have higher volumes there. They are getting some compassionate supply from the company. It's not widespread. It's been out only for 3 days, this approval, and it is not a cure. It drops the infectivity, or drops, not effectivity, sorry, it drops the symptomatic presentation of the disease from, I think, 15 to 11 days. It doesn't seem to be a big deal, but when you know that the problem we have with a severe extreme sick people is the congestion of the system. And this, by cutting 4 days in every patient that you get into the ICU, that's a great achievement. So that's what it is approved. To answer your question, that they're asking to buy, yes, you have to buy some. I wouldn't go crazy on buying too much and spending too much money and buying it. I might have a deferred contract where you get, you know, maybe have for 50, 60 patient supply or less, and have potential to get more if needed. That's how I would do it. I wouldn't stack too much, but I wouldn't stay without any at all.
شكرا دكتور خالد. شكرا دكتور هشام، تفضل عندك سؤال.
السلام عليكم.
وعليكم السلام.
هشام القبلاوي، طبيب نساء ولادة في وست فيرجينيا، الولايات المتحدة. مشكورين جدا جدا الزملاء خالد ويحيى وعصام على هذا التقديم وهذه المحاضرة القيمة. الحقيقة أنا عندي سؤال لخالد إذا كان بالإمكان. يعني في كيس ريبورت وزي ما تفضلتوا كلكم تكلمتوا على المشكلة أنكم ممكن تكون فيها clotting problem, thrombosis and clogging vessels. And some, you know, I'm sure all these cases, they will have some thromboprophylaxis. Are there any thoughts about, I've heard maybe there were a case report by using thrombolytic agents like TPAs. And since the problem is not ventilation, is not an oxygenation, is a problem at the vascular level. Maybe some thoughts, they say ventilation may be even more harmful, maybe causing more lung damage. So I don't know if there is any new evidence, any more information you could highlight that. The second question to Yahya, are there any rapid testing? What we face here, fortunately here in West Virginia, we don't have many cases. But in our labor ward, just like everywhere else, everybody get tested. If they come in electively to be induced or have elective cesarean section, they get to be tested beforehand. In our hospital, it takes about 24 hours. So those people who are coming in labor, is any availability of rapid tests or anything in the near future you're aware of? أخيرا سؤالي الثالث لدكتور عصام، تكلمت عن الكوترايزيشن والسموke inducing. It's very well known that the HPV, human papilloma virus, when we use cauterization for the cervix, it will generate smoke, and that smoke has particles of HPV. However, how do you contain in open surgery when you use your cautery? Of course, when you do a laparoscopic procedure, it's a closed circle. You could use tubings and suck all the smokes, but in an open surgery where you have the bovie used on subcutaneous fat, of course, some people that just use, the smoke extractor, the tube just beside the bovie. Are you using anything different than that? I appreciate it, and thanks very much for this valuable lecture.
أبدأ يا عصام أو يحيى.
أنا إجابتي سريعة ممكن قصيرة. بارك الله فيك دكتور، مرحبا بك معنا. عفوا أنا البيج is going off. بالنسبة للموضوع الكوتري, I think as you know in our hospitals now across the US, there's a lot of concern about smoke from the HPV era onward. So the trend has been always to try to contain it. We are actually trialing Ethicon and Covidian and a bunch of ones even now because of what just happened. Like there's a big tubing, smoking tubing that is connected to the bovie itself. That's one. Now we're required to wear the N95 in the OR when we're doing cases that involve the potential for a lot of smoke in a case. But aside from that, I think it's a risk complicated by the fact that there is air exchange in these procedures, and so the concern is that if the virus is in the tissue, can it be transmitted this way? That it could be theoretical, but I think in the panic mode and the concern, everybody's doing it. So those are the things we're doing. We're not doing anything magical, but in the laparoscopy, we're doing extra things. We've added machines that actually would suction the air constantly. We're not allowed to vent the ports, which sometimes we do, as you know, when we're doing the procedure. And we're also wearing the N95s, which is under, on top of the other masks. So those are the practices, but nothing more than that. Thank you.
Okay. Hisham, Assalamu alaikum, كيف حالك? It's been a long time since last time we saw each other. And I don't see Rida Hanai, so you need to put some pressure on him to show up. Okay, so بالنسبة لجورجتاون Washington Hospital Centers, what we did is we divide the surgery into two. Okay, there is one which is emergency surgery. Okay, and on those sort of things, if you have like a appendectomy, C-sections, anything that you need to move the patient to the OR immediately. Okay, you have to do all. You do it with air protection, as Isam mentioned. If you have times, we chose to do the PCR, which is the QStat, and the gene expert, which is about 45 minutes the turnaround time. So 45 minutes is not that bad if you can delay those cases for 45 minutes. If and slowly, we, as Isam mentioned, that we are moving into subacute cases or chronic cases. So what we chose to do is we developed tents outside the hospitals where the patient comes in. We took the nasopharyngeal specimen from them, as the probably the OB does not do it, but most of the the orthopedic surgeons routinely they do the MRSA testing, which is also a nasopharyngeal swabs prior to surgery. So we have tents outside the hospitals, and the patient will drive through. We'll collect a specimen, and we'll send it. We will run them once a day, and the turnaround time for those testing is about 24 hours. It's another PCR methodology, but it takes about between 5 to 6 hours to get the result out. But the most important thing is the patient, the minute that the specimen is taken, he has to quarantine himself until the day of surgery. This is regarding the testing part. I know that Isam talked about the N95 as well as Khalid. We are running out of PPE, by the way. I see some names, Galifin State, and we are moving toward recycling those PPEs. So the N95, we take them out, we put them in a bag, we store them in one area, and we do with them. And the other way to do it is to put the N95. You either put a shell in front of the N95 so you can reuse it, or you can put the surgical mask on top of the N95 so you can prolong the time of using of the N95 during the ED or ICU or the OR, you know. But we are running into draining our PPE in this area. Correct.
تفضل دكتور خالد.
Hisham Basha, I really forgot your question. Yahya talks too much.
Okay.
He's just a little jealous, Hisham Rao, best. And you know, those people are in the desert, so they don't have no one to talk to, right?
Yeah. Nice to see you. I saw your son at the camp.
Yeah.
دكتور خالد، هو وقت الافطار تو في ليبيا، احنا ماذا بينا لو كان دكتور هشام يعاود السؤال بسرعه، وعندنا دكتور علي المقدمي ماذا بينا نسمع. اهلا وسهلا بك دكتور علي، استاذنا في الجهاز امراض الجهاز التنفسي، لعل يعطينا فكره على الاقل دقيقه او دقيقتين. هو صح وقت فطور لكن نستفيدوا من الموجودين. كذلك دكتور عبد الحميد الفلاح، اهلا وسهلا بك، اخصائي التخدير طبعا معروف في ليبيا، ونتمنى تكون غدوه معنا ان شاء الله الساعه 10 في الليل. تفضل دكتور هشام.
Khalid, my question was, there is a growing evidence about microthrombi and thrombosis and a vascular problem rather than a ventilation and oxygen in the alveoli. As I heard that probably might be a case about thrombolytic agents and maybe even ventilation could be even more damaging rather than helping, especially in those very sick patients.
Okay, so yes, actually lately it's been considered as part of the diagnosis of COVID, what we call the COVID toe. So we do see a lot of patients who have disseminated coagulation. We see DVT, we see PE, we see clots around the large lines. We see all this stuff, and the strategy, as I showed in one of my slides, is shifting. Now every hospital is doing a little bit different, but most people, we are anticoagulating every patient who is in COVID, whether stable or not. We either do prophylactic in stable younger people with probable good outcome, and people with high D-dimers, we probably go to a full anticoagulation. About the thrombectomies, it's not been it's more disseminated. There are a couple of centers that are trying to see if they can solve the problem by embolectomy, like if they find a localized thing like around the central line or in the PE, but nothing firm came out of that. So it's not a widespread practice, but the anticoagulation is definitely. And if I have a second to answer a written question for Dr. Abdenbi that he said he will ask tomorrow regarding the الناس المحتجزين برا. But before I go there, Hisham, do you have any? Did I answer your question? You have any?
Yeah, my question is not embolectomy. It's using TPA, for example, as a thrombolytic, IV, thrombolytic agents.
Okay. Well, I personally don't use it. Our institution, I haven't heard of anybody used it. I am not aware that there's anything out in that regard to use thrombolytics.
Can I add only one thing, Hisham? By the way, there's a study that came from New York about 30% of moms that came to the hospital that for delivery, they were positive for COVID-19 and they did not show symptoms. We moved about 2 weeks ago, and we are testing all delivery moms in this area for COVID before, once they come to the hospital. But
Okay.
no evidence of transmission to the baby, by the way.
Okay, back to Dr. Abdenbi's question about the people stranded outside very quickly. I was never in favor of quarantining people outside. I know this is the big problem right now, because as I mentioned earlier, there is a transmission when you put a big group of people in one place, unless you do 100% isolation, which is not happening. You are just increasing the burden of the problem. My opinion is do a PCR, send them home, do another PCR to improve sensitivity, and regardless of the result, they have to be quarantining themselves for at least 2 weeks. Other than that, it's just going to be a very difficult process. شكرا.
شكرا لك دكتور خالد، شكرا دكتور يحيى، شكرا دكتور عصام. في دكتور علي المقدمي لو كان موجود قاعد موجود معنا، لو كان يبي يضيف حاجه. دكتور علي، وقت فطور في ليبيا اعتقد الجماعه كلهم ذهبوا.
كيف فطرنا والله يا شباب، كيف فطرنا والله، بارك الله فيكم، مشكورين جدا.
معاكم يا اخويا.
اللهم امين، بارك الله فيكم، والله مشكورين جدا على اهتمامكم بليبيا وبالليبيين. موضوع العايدين العالقين في الخارج وعودتهم يوم الاثنين او الثلاث، والله ما ارقتنا هلبة. انا نصفها كأنها حقبة الكورونا في ليبيا قبل رجوعهم وبعد رجوعهم. للاسف حيرجعوا ب other strains of viruses most likely. Many of them might be having chronic diseases, older ages. فاحنا خايفين من الموضوع هلبة، ومتوقعين انها المسار متاع الكوفيد مش حيكون يعني زي ما هو في الشهر اللي فات، حيختلف هلبة بداية من الاسبوع الجاي. ان شاء الله خير.
ان شاء الله ربي يجيب اللي فيها خيره، وان شاء الله بجهودكم ونتعاونوا مع بعضنا ان شاء الله وبالاستشارات، وان شاء الله نقدروا نوصلوا باذن الله لبر الامان باذن الله تعالى. شكرا جزيلا لكم جميعا، ربي يحفظكم. لو كان في حد عنده كلمه اضافه يتفضل. دكتور عصام، دكتور يحيى، دكتور خالد.
لا مشكورين، وكونوا معنا غدا يعني. بس
غدا ان شاء الله حيكون عندنا موعد باذن الله الساعه 10 ليلا الى الساعه 12 في الليل
ان شاء الله. دكتور خالد، يعني حتى لو في امكانيه هي كيفيه انتشار الخبر، بحيث ان يكون الخبر منتشر في ليبيا كلها، في مشرقها ومغربها وجنوبها، بحيث ان الأكثرية من الناس يستفيدوا من النقاش هذا إن شاء الله.
لا موجود إن شاء الله، تم التوزيع. موجود.
نعم.
موجود. دكتور عبد النبي الرئيس عنده علم من يوم الأربعاء، والناس
نعم.
عارفة.
لا بس يعني إذا كان في نوع من التغطية، الإعلان والتغطية على المواضيع كيف هذا، ويستغلوا الناس اللي هم معروفين في نشر المعلومات، بحيث إن الناس أكثر يعرفوا بالموضوع هذا.
نسقوا مع الدكتور عصام ان شاء الله من خلال باذن الله تعالى. شكرا جزيلا لكم جميعا، واللقاء غدا.
اوكي
بارك الله، صح فطوركم ان شاء الله. مع السلامه
جميعا.